So, first slide, essentially, we talk about what's the difference between hospice and palliative care. The way I typically think about the difference is, palliative care is the big umbrella term that encompasses goals of care conversations and symptom management, right? We can do that alongside the patient and their family as they're going through whatever treatments they want to go through. Whereas hospice care falls under that palliative care umbrella. It is a type of palliative care, but it is specifically for people at the end of life. We're talking reasonable expectation of 6 months or less to live. Okay? They do the same thing, same goals of care conversations, same symptom management, but they do have that prognosis of 6 months or less. So in a sense, hospice care is palliative care, but palliative care is not hospice care. That's a very important distinction. Okay? Next slide, we talk about clinical signs that correlate with prognosis of less than 3 days. So this is good for you all to know as you're doing your assessments, also good for us physicians to know, and it's so that we can counsel our patients and our families. At this point, it's probably more families because patients will probably be asleep and unresponsive by this time. But those signs and symptoms could be loss of radial pulses, okay? What we call mandibular movement with breathing, but it's really that agonal breathing pattern, okay? Kind-Stokes breathing, so where you have that breathing pattern of really, really fast, slow down, stop, then really, really fast, slow down, stop, okay? And that pattern just repeats itself. What we call terminal congestion, so the death rattle, right? And if they're anuric, so not putting out, they're putting out less than 100 cc's of urine over a 24-hour period. Okay, so I've seen data that says that any of these signs could mean 12 hours or less, 24 hours or less. We say 3 days or less. So prognostication is not an exact science, right? We're just kind of giving an estimate. Okay? These all might be present, 1 or 2 might be present, so it's just something to be on the lookout for. So our next slide, changes in respiration. Tends to be one of the more distressing symptoms for families at the end of life. What I usually tell my families is that we can see kind of any number of breathing patterns as they're going through the dying process. So it could be really fast breathing, it could be really slow breathing, it could be normal breathing, it could be that Kind-Stokes breathing that we just talked about. It's important to, at least I think, to highlight to families that whatever the breathing pattern might be, if the patient's unresponsive but looks otherwise comfortable, that's what's more important, right? That they look comfortable, their body's relaxed, their face is relaxed. I oftentimes get called about, patient's comfort care, they're unresponsive, they're breathing really, really fast, can we up the morphine or can we up the fentanyl? We can try a one-time increase, that's usually what I tell folks, but if it doesn't change the breathing pattern, then probably nothing's gonna change the breathing pattern, right? At least within responsible and reasonable doses of pain medicine. Clearly, if we go up high enough on pain medicine, it's going to change the breathing pattern, but that's not our intent, right? Our intent is not to hasten death. It's just to keep the patient comfortable and allow them to die naturally. For the next slide, in terms of dyspnea, so it's important to just keep in mind, I think dyspnea is a subjective symptom, right? So it's something that the patient should report to us. It's not an objective sign, such as like respiratory distress. We can use oxygen at the end of life, but really we should be using it more as for comfort, and we shouldn't really be titrating up and up and up and up and up on the oxygen, okay? And another thing to remember too is if our patients are really kind of pulling at things and trying to get that mask or that nasal cannula off, maybe that's a sign that they just don't want that on, that's not comfortable to them. And if the family is agreeable, take that off. If they're giving you a little more pushback, I would say try to counsel them on the reasons why that's probably not comfortable to them, and see if we can come to a shared decision that, yeah, let's take that off. Okay. For people who look short of air, sometimes just having a fan breathing or blowing across their face will help with that sensation of dyspnea. So sometimes we'll put that in the orders. Opiates such as fentanyl and morphine do help with air hunger as well, like we talked about before. Benzos, Ativan, Valium, whatever, Xanax. We typically use Ativan. They help with anxiety. Obviously, you can get into that circle of I'm short of air, I'm anxious, now I'm short of air, kind of that cycle. We would want to reach for the opiates first when it comes to shortness of air, because we know that opiates work in the brain, and when they work in the brain, they kind of shut off that signal to the patient that I can't breathe, right? So even though they might be breathing 30 times a minute, if they have opiates on board up here, they don't feel like they're short of air. Does that make sense? Whereas benzos don't really affect those opiate receptors. They will calm the patient down, but it might not affect their sensation of air hunger. Okay. Next slide is about excessive secretions. We oftentimes refer to that, especially at the end of life, as the death rattle, one of those prognostic signs that we're nearing the end. Typically, or actually most of the time, if not all the time, we know it does not bother the patients because, again, by this time they're unresponsive and they're not interacting with us. This death rattle tends to be most bothersome to family members or friends that are at bedside. We do have, especially for our comfort care only patients, we will have Robenal ordered as needed. Typically I do it every hour as needed. The important thing to remember about Robenal is it dries up everything, right? So the mouth gets dry, the eyes get dry, just everything dries up. It does help with the sound of that terminal secretions, but at that point I think a lot of times we're using it more for the family, for us as caregivers to kind of make that sound go away. So an important thing to remember is sometimes it's as simple as turning the patients on their side or just repositioning and letting gravity take effect and kind of move those secretions around so it doesn't sound as prominent. And so sometimes we'll, especially over at the High C, which is the inpatient center for hospice, they'll put them in the recovery position, which is essentially just put them on their side and just passively allow those secretions to drain out of their mouth. And it might save you a dose of Robenal for the patient. We don't, in terms of secretions, airway secretions, we ask not to do any deep suctioning. So if you're going to do any kind of suctioning, just keep it right in the oral cavity. Okay, no NP suction. This part of the reason why we talk to families about foregoing artificial hydration or artificial nutrition is for this. The more fluid we're putting into a patient at the end of life, the body doesn't know what to do with it, right? The urinary system shutting down, so it's not eliminating the urine or eliminating the fluid through the urine, so it can cause more airway congestion. So that's one of the reasons why we talk about not doing those things at the end of life. And we'd also talked about the Robenal. There's other medicine, hyoscyamine, atropine, that we could use to dry up those secretions. Both of those medicines can cross the blood-brain barrier, puts the patient at higher risk for delirium. Fun fact, Robenal does not cross the blood-brain barrier, which is why we like to use that more frequently, because lower incidences of delirium. Speaking of delirium, the next slide, terminal delirium. Delirium can kind of show up in one of three different ways. It could be a really agitated delirium where they're picking and trying to get out of bed and just very active. Or it could be a hypoactive delirium, which kind of mimics depression in a sense. Very difficult to determine if it's depression or delirium. It could be a mixed presentation too. It could be one minute and the next the other. But it can be dangerous to patients and very highly distressing to patients, especially if it's that hyperactive delirium. Okay. I think it's important, especially if we're dealing with the dying process. Again, to educate families, this happens at the end of life sometimes. And the best thing that we can do at that point, which is on the next slide, is probably use medicines like Haldol to try to get them relaxed and calm down. Okay. Again, for my patients at the end of life, I typically, as long as it's okay to use with the patient, every patient's different, of course, I'll typically have Haldol available for you every hour as needed. Okay. If we have someone who has Parkinson's disease, we might use something a little different than Haldol just because of the pharmacology behind it all. Benzos like Ativan can make delirium worse. So if we think it's agitation due to delirium, we probably want to go with Haldol if we can. If it's agitation without delirium, teasing it out can be tricky, but if it's simply just agitation, like they're totally with it, they just can't get settled, probably Ativan would be fine in that situation. But the caution with Ativan and other benzos is it can cause a paradoxical reaction, especially if it's delirium. It make things worse. So just keep that in the back of your mind. The next slide is general comfort measures. What things we want to do, keep them in a private room. So all of our comfort measure patients get a private room here at the hospital. Turn off all the telemonitors, silence any alarms. Try to minimize your interactions, or minimize interactions in such as where you're disrupting the patient. We still want you to go in and check up on them, make sure they're comfortable and doing well, but vital signs we'll typically just do once a day, so we're not going to do every 4 hour vital signs anymore, right? Just let the patient sleep and be comfortable. We typically take off any seat collars on, or SCDs, or just anything that's not natural for the patient to have on. We'll take those off. We need at least, hopefully, one IV access. Okay, we don't need central lines. We don't need PICC lines. We can need a peripheral if we can. If we lose the peripheral, we can do these things sub-Q. So just let us know. It's not a big deal. If we lose the peripheral, we can't find another place, we could try sub-Q. Okay, and sometimes we can even do sublingual, depending on the situation. Okay, so we can even do sublingual medications. We'll stop doing lab tests. Stop doing the glucose finger sticks. Okay. And then if the patient's still somewhat alert and awake and they ask for something to eat or drink, let them have it. We want to be safe. We don't want them to aspirate. We talk to the families about the risks of aspiration, again, depending on the patient's situation. But small bites, small sips and things for comfort, that's fine. If the patient is unresponsive and they're not going to wake up and ask for those things, something you can educate families about, or friends, is just to do good oral care. Give them some of those pink sponge swabs and have them dip it in water, dip it in soda, dip it in coffee, whatever the patient liked to drink. Keeps the mouth moist and gives some flavor in the mouth and things like that. Okay, and it gives the family something to do, right, while they're there with their loved one. We do like to kind of gently reposition our patients every couple hours. I know I said don't mess with them very often, but think about how comfortable is it to lay in one position for a very long time, especially if you have bony prominences and things. So, gentle repositioning every couple hours is good. Frequent oral care that we talked about, and we also have artificial tears ordered to keep those eyes moist. Okay. Next slide's about medications that we use. So pain medicine, anxiety medicine, Tylenol, Robenol. Like I mentioned earlier, our intent is not to hasten death in any manner. So we're going to prescribe doses that we think are safe for the patient, that keeps the patient comfortable, but is not going to be dangerous for that patient. Okay. I'd encourage you all, if you have concerns about those things, just to ask us as the physicians, and we'll try to talk you through and address those concerns. And if we're doing something wrong, we want to know about it too. Okay. There are times when we will schedule pain medicine or schedule Ativan anxiety medicines, and then also have PRNs available. It's important that those patients that have scheduled comfort meds get those medicines as we have them ordered. Okay, we've calculated the dose, we've calculated the frequency, so that we're maintaining their comfort, but again, we're not hastening death. It will be a safe dose. We sometimes see, especially the overnight doses, the 4 a.m. doses or so, will sometimes not be administered. And the problem is when the patient wakes up at 6 or 7 in the morning, they miss that scheduled dose. Now they're in a lot of pain or discomfort. Okay, so we have those scheduled to maintain a nice level, smooth level of comfort for them. Okay. We'll have vast majority of the time they'll have as needed, whether pain, anxiety, Haldol, whatever, you'll have those available. And it's to be given as needed, so if the patient's requesting it, if the family's requesting it, but also if you all are doing your assessment on a nonverbal patient and they look uncomfortable, the brow's furrowed, they're restless, they're agitated, they're having a very difficult time breathing, they look tense. Use those physical signs to say, okay, this patient's not comfortable, let's give them a dose of something to get them more comfortable. The next slide talks about nonverbal indicators of pain. Some of the things I just talked about. Other signs could be moans and groans, grimaces. They're really grasping the handrails. Very tense body. Can't seem to get comfortable. They're restless. Can't sit still. Or if they're awake and kind of rubbing the affected areas. Those could all be nonverbal signs that they're not doing well in terms of comfort care. If you have any questions about those things, ask a supervisor, ask us. We're happy to come help and assess and talk about it. Next slide is about implanted heart devices, so AICDs in particular, pacemakers. We will have those conversations with those families in terms of, do we keep those devices on or do we turn them off, right? Vast majority of the time, we keep pacemakers on, okay? Unless the patient's just like, nope, doc, I want it off, turn it off. I get the risks. We will in those instances, but the vast majority of the time we keep pacemakers going. Pacemakers don't shock, right? They just kind of keep the heart going at a nice constant rate. However, we will discuss turning off AICDs. And the reason being is, as we're dying, our hearts might go into some weird rhythms, and that AICD is going to shock them, right? We don't want that to happen. That's not comfortable. So we will talk to patients about it. I'd say the majority of the time, the patients or the family are agreeable to turning off that AICD. If they're not, that's their decision, and we just do the best we can of keeping them comfortable through those shocks. Okay? 2 ways, really, to turn off these AICDs. If we think there's not much time left, we can always put the big donut magnet over top, okay, and just tape it down. It's not the most pleasant thing, but it works, okay. If we have some time, we can always have cardiology come up and turn it off. If they're busy, we can always call the device rep to come up and turn it off, okay. But the magnet's a good kind of stopgap measure until we get those things accomplished. And then I think the last slide, I appreciate the patience, is just about our team in general. Got some numbers on the slide if you need to page us or get a hold of us, and some things that we do. I think the important part about this slide is when to call us versus when to call the primary team. So we're never primary, we're just a consultant service. We can't admit, we can't discharge, okay? So really, when a patient dies, we don't pronounce them. It's the primary team that pronounces them. So just keep that in mind. Call the primary team, whether it's 8 in the morning or 2 in the morning. It's not our responsibility to pronounce them. Okay. I'm sure you guys know most of us. Dr. Pate, myself, Emily King, and then Kirsten's our psychologist. LJ's our chaplain. And Mona, at the moment, is our secretary. She's probably the one you talk to most on the phone when you call the office. So we made it through the slides. Any questions, comments, concerns?
Resources for night shift. Do you want us, if we are doing an assessment and we feel that we need, when we have to consult you for an extra dose, do you want us to call you or the primary team? What are the resources for our night shift nurses?
If it's symptom control concerns, page palliative care.
Okay.
If you need eyes on the patient right then and there, it's probably page the primary team because we're just not in-house.
Okay.
We're happy to help with that. And if we're doing our job on the front end, usually all my PRN orders are every hour. So if you feel like you need a dose increase, for sure, give us a page. That goes for any time of the day.
Okay.
And how much oxygen is like the comfort oxygen? Or is that like varies? Like I can't just throw on like 2 and that's fine? Or?
I think the order set, because there's a couple order sets that at least that I use for comfort care, and I think the order set says start at 2.
Okay.
But it's going to vary depending on if they come in already on 6 liters.
Okay.
It's probably going to be 6 liters, right? So.
Any other questions?
Thank you all.